I'm Dr. Miller, and I have the pleasure and the honor to introduce Dr. Farrar and her talk. Dr. Farrar works with us in the geriatric psychiatry department. She initially got her undergrad from the University of Washington in computer science, and then went to Boston University and got a Master's of Arts in Medical Science. And she later pursued a Doctor of Medicine and a Doctor of Philosophy, finishing in 2018 with the MD and PhD. She then came out here to Albuquerque, New Mexico, where she did a residency in psychiatry. And in July of 2022, joined us on faculty. And so she's in her second year as an assistant professor here at UNM. Her PhD dissertation title was Brain Networks Involved in Decision-Making in Electroencephalography and Magnetic Resonance Imaging Study. So she has had an interest in cognitive neuroscience and has continued that interest here. And so she is going to present on long-term potentiation and neuromodulation, specifically electroconvulsive therapy. So without further ado, Dr. Farrar.
All right, thank you. Thank you, Dr. Miller, for the introduction. Let me go ahead and share my slides. All right. There we go. Okay, can everybody see that? Or Dr. Miller, can you see that?
Yeah, we see the next slide too.
Okay, you see the presenter?
Yeah.
Mode? Let me. Can you see that now?
Perfect.
Okay. All right. So today I'm going to be talking about a research project which is under development, or I am starting to pursue, answering the question, does disrupted long-term potentiation underlie cognitive changes during ECT treatment? So the learning objectives for today is, first I'm going to talk about cognitive changes that occur during ECT. Then we're going to talk about long-term potentiation, a review from some basic neuroscience. And we're going to talk about using electroencephalography in order to mark long-term potentiation. Then I'll talk about my project proposal, which is to measure long-term potentiation and cognition in acute phase ECT subjects. And I have no disclosures to report. Okay. So ECT is a highly effective treatment. I think most of us know that it has a very high remission rate of depression. 60 to 80% is cited in the literature. However, cognitive impairment is the biggest barrier for people to pursue or continue treatment, which then prevents the use of this treatment that is much needed for a lot of our patients who have treatment-resistant major depression. So subjective cognitive impairment is frequently reported. So in a meta-analysis, they found that about 48% of people who are treated report cognitive impairment, and they report mostly memory loss. And I think that all of us who have taken care of people undergoing ECT have probably heard this. And it's distressing to people. They feel like something is off. So for objective cognitive changes, and this is from a big meta-analysis done in 2010, there are a lot of objective measures that show changes in memory and changes in executive function and verbal fluency, most notable. Now, this is worst at 3 days post-acute treatment. So when they finished their acute series ECT, 8 to 12 sessions. A couple of days after that, they will note the biggest, or they will demonstrate the biggest decrease in cognitive performance. However, most people by day 15 are back to baseline or better because, as we know, depression also causes cognitive impairment. So some people with, or a lot of people with remission of their depressive symptoms will actually do better afterwards. We know that ECT parameters, and I'm not going to get into those too much, influence cognitive changes. Most notably, and what I'll talk about a little bit here, is that electrode placement is one of the factors that seems to substantially influence how people perform cognitively. We know that people who undergo bitemporal treatment tend to do worse or have more cognitive side effects than those undergoing right unilateral treatment. So the right unilateral treatment, there's only one electrode that's delivering current. And then in bitemporal treatment, there are two electrodes delivering current. And these are the most common configurations used, and it's what we use here. So this is just a chart that I think nicely illustrates that the electric field experienced by the brain, with the bitemporal electrode placement, you can see red is very high. It's a much bigger electric field experienced with the bitemporal electrodes rather than the right unilateral. And so likely there is, this is likely a contribution to the reason why people experience worse cognitive impairment during bitemporal electrode placement. So we don't really know why people experience cognitive impairment from ECT. What has been proposed or floating around in the literature is this notion of disrupted long-term potentiation that is underlying the cognitive impairment with ECT. This has not been studied directly in a population undergoing ECT. So if you recall from neuroscience, basic neuroscience, that long-term potentiation is a proposed mechanism of learning and memory that was described by Donald Hebb in 1949 and often stated incorrectly attributed to him is this summation of his theory, which was that cells that fire together wire together. And what this means is that learning and memory arise when you have increased synaptic efficiency triggered by the coordinated firing of the pre- and postsynaptic cells. So this is a nice illustration of what we're talking about. So this is the axon terminal of a neuron. And, you know, an action potential occurs, it comes down here, it triggers the release of neurotransmitters. The neurotransmitters go into the synaptic cleft. They join to a receptor, and then there's an influx of ions that goes through the dendritic spine, and these all the dendritic spines sum together and can form another action potential if it's a sufficient influx. Now, if you increase the synaptic strength, meaning you perform this numerous times, you end up in this potentiated state, which means that not only do you have an increase in the neurotransmitter release, but you have an increase in receptors, which means that there is a bigger influx and you are more likely to trigger an action potential. So we're saying that the strength of the synapse here is increasing when you have this repeated stimulation. Now we're going to talk a lot about tetany, which is a high frequency stimulation. So here we are inducing an increase in the synaptic strength by very frequently stimulating, and in order to achieve this potentiated state. So now we're going to talk about what happens during ECT. So this comes from a paper that was published in 1976, often cited in the ECT literature still, in which Hess and Taylor, they took a rodent or a series of rodents and they put electrodes into the hippocampus of the robot. They both stimulated and measured the potential from the same area of the hippocampus. And so they recorded a baseline, and this is a recording of the potential at baseline after the stimulation. And then they tetanized, or did the very high frequency stimulation of the rodent in that part of the brain. And they, after repeatedly doing this, the final measurement that they show has this increase in the excitatory postsynaptic potential, or the EPSP, the measurement has increased as a result of repeatedly stimulating the that region of the brain. And then they induced a seizure, or they performed ECT on the rat. And you can see that they interrupted this signal and they've achieved postictal suppression. Then they repeated the measurements. So when they next measured this, there was still some potentiation left, so to speak, in that they had measured a higher potential than the baseline, but it's much lower than where they were at B. They retetanized numerous times and then and achieved a max here, which is lower than the max from before. And then they induced a seizure, and they then tested this again. And what we find is that despite repeated tetany, we're still not achieving that same potentiated response as they were before. So to just bring this back to the model described, we are in the beginning, they were showing with the enhanced or potentiated synaptic expression, they were able to increase the potential based on tetany. And then in performing ECT, or inducing a seizure in the rodent, they had a disruption of the long-term potentiation, even when they repeatedly tetanized the rodent again. So returning to kind of the idea behind this proposal, the question is, does disrupted LTP cause diminished cognitive performance during ECT? And so we're going to be testing this in humans, but kind of relating this back to the rodent, we are expecting to see, by measuring at a pre-ECT time point, seeing the potentiated response being robust, mid-ECT anticipating that it would be somewhat diminished, and post-ECT expecting to see that it is even more diminished. Now, we will measure this by measuring LTP at each of the 3 time points and looking at the changes between the time points, measuring cognition based on cognitive testing at each of the 3 time points. And then we keep track of depression because that is the clinical outcome that we are expecting from ECT treatment. So the question is, how do we measure LTP in a non-invasive manner in humans? So we're going to use an electroencephalography, or EEG, which is a recording of the sum potentials of cortical pyramidal neurons through the scalp. And as a review again, what EEG measures is, if you recall, the cortex of the brain has these nice pyramidal neurons that are oriented in parallel, and you end up with charge circling around the dendritic portion of the neurons, and that can be detected through the scalp if the electrode is placed on the scalp because of their parallel nature. So other parts of the brain aren't really detectable because they are not oriented so nicely, and so we have a lot of parts of the brain that are deeper that are organized more randomly. Okay, so what we're going to be using is the visual evoked potential. So what a visual evoked, and this is an EEG measurement, what a visual evoked potential is it's the electrical signal generated at the visual cortex, so in the occipital region, in response to visual stimulation. This is a highly reproducible signal, both in humans and animals. And it's often used by neurologists for diagnosis of visual or cortical pathology. It can also be used as a marker of LTP. So to elaborate, if you recall the structure of the visual pathway, starting at the eyeballs and the optic nerve, crossing at the optic chiasm, and then going to the occipital cortex where, we're reaching those nice pyramidal neurons. So how the visual evoked potential is generally generated is by showing people or animals a bunch of checkerboard flips. So this would be flashing checkerboards, and at every flip, the white square becomes black and the black square becomes white. And you end up with a nice, what's called, the nice visual evoked potential, which is this waveform that signifies that this process is happening. So how you come about deriving a visual evoked potentials is you have a person, again, looking at this checkerboard flip. We've got this continuous EEG recording, and it's pretty noisy. If you guys have looked at EEGs before, you know that they have a lot of signal there. But we mark every checkerboard flip, and we take an average of each of these intervals, or epochs as they're called. And a lot of the noise falls out, and you get this nice waveform here. And we also do this over populations in order to generate enough of a signal to be able to draw some conclusions. Okay, so the question is, what does this have to do with LTP? It has been found that if you show a person, a human, this nice visual evoked potential, and usually this is by doing a 1 Hertz flip presentation. So about every second the checkerboard flips, and you measure the visual evoked potential at that time. You can tetanize them, same as they were doing by stimulating the rat, and induce a bunch of really rapid checkerboard flips, thus inducing a potentiated state. So again, performing the beginning paradigm, but now after the tetany, you can start to see changes in this visual evoked potential. So this is kind of a nice summary graphic of what's been found. And what they have found are that you can see this changes in the visual evoked potential, and you can see a pre-tetany and then a post-tetany potential that shows a difference that suggests long-term potentiation. But the question is, how do we know that this reflects LTP? Because it's still kind of a jump. So they've taken slices of hippocampus from humans, and they've done this kind of tetanic stimulation of the hippocampus and recorded the EPSPs, much like we were just talking about in the rat or the rodent. They recorded something similar where, you gather a baseline, you do the stimulations in a non-tetanic fashion, and then you tetanize, and you see this increase in the potentiation over time. Now, they extended this to look at the same phenomena in the visual cortex of the cat and the rodent, to show that the same phenomena happens in the visual cortex as the hippocampus, which is helpful because, the question is, how does the hippocampus VEP or the hippocampal LTP relate to the visual LTP? And this is the connection that we have that shows that the same kind of phenomena occurs in both types of tissue. Next, there was a study done by Cook and Bear in 2010, and this was nice. They did theta burst stimulation on a rodent, or a series of rodents, and then they did just the visual stimulation. So this right here represents the potentiated signal that happens after the visual presentation has occurred, and this is the signal that has happened after. they've received theta burst stimulation, which is a form of tetany. You can see here that the non-TBS, are joining with the TBS VEP amplitude over time. And then they've also just shown that by showing these rodents, this is a separate study, they've shown that these rodents, when they see the checkerboard paradigm, they see the same increase in potentiation. So from that, we can at least infer that this visual evoked potential is a similarly representing long-term potentiation after performing a similar paradigm in humans. So the goals of my project, the aim is to measure changes in LTP-like phenomena, which is what the visual evoked potential is, and cognitive performance during an ECT series. So my first hypothesis is that subjects with impairment on the California Verbal Learning Test 3, or the CVLT3, their memory performance will correspond to decreased LTP-like phenomena as measured by the VEP. And then the second hypothesis is that subjects who have bitemporal electrode placement will have decreased LTP-like phenomena compared to right unilateral electrode placement. So the timeline for an individual participant would be that they come in, they get screened at baseline, and this is right before they do ECT, they undergo the cognitive testing, depression measurements, and then they get their VEP measured. They undergo 6 ECT sessions. Everybody is undergoing right unilateral ECT. At the midpoint, we will repeat these measurements. So the CVLT3, the depression screening, and then the VEP. And then those who are not responding adequately to the treatment, their depression scores are not changing, then they would switch to the bitemporal electrode placement. And then after they complete their series, we would again perform these measurements. The plan is to recruit and test about 12 subjects between a week or so from now and from June of 2024. And this is kind of in line with the other ECTs studies that are ongoing. Participants can be dual enrolled in the other studies as well as this study. And we've got a pretty robust pipeline here of participants. So the paradigm setup, and this was adapted from an earlier, VEP setup, is to test at baseline the visual evoked potential, undergo the modulation, and then repeatedly test the the changes in the visual evoked potential over time. Now, this is kind of to track the changes of the visual evoked potential over time, even though kind of these later potentials are the ones that we anticipate being most of interest, because that is consistent with what has been found in the literature. They see frequently that the change in potentiation is greatest right around this time point. Okay, so just to back up a little, or to move forward a little, looking at some of the data from the most recent ECT study, we looked at the California Verbal Learning Test subscores as people undergo the ECT series and compared them by electrode placement. So what we're looking at here is there's an average of the difference between the midpoint visit and the endpoint visit. And the reason we picked the midpoint is that is when people switch to bitemporal or they stay right unilateral. So that's really the point where the treatment diverges. So subtracting the final from the initial, negative reflects improvement. So what we see overall is that for almost all of these subscores, of the learning test, the right unilateral or the people perform better. And it is worth noting that these scores are not accounting for practice effects, which could or are likely to be underlying the improvement that we're seeing here. And so further analyses would incorporate a control for the practice effects. So what we are seeing, so overall, is people undergoing bitemporal electrode placement tend to perform worse. So I highlighted this because this is a nice summary score that is more or less significant, showing a very big difference between the two electrode placements. And the effect size is 0.72. So if you recall, 0.8 is generally considered a large effect size. So we've got good effect sizes between these two groups. So I'm highlighting this as the measure that I would hypothesize would reflect the biggest change, but when incorporating it into testing the hypotheses that I outlined before. And then in the literature, here's an example of published evoked potential of the visual evoked potential. This signal here, the N1, is the most reproducible signal across studies using visual evoked potentials as a marker of LTP. So these are my very preliminary data collection. So these are individual control subjects taken from the occipital midline electrode. I put these up just to show again how reproducible this phenomena is, that you can see the very clear waveforms. And then what these are it's showing the baseline measurements, as well as these are the subsequent measurements. Really, we have to take a population average in order to be able to see if there's any significant effects, but it's just here to illustrate kind of what we are able to collect so far. Okay, so after I finish this project, the plans are next we first of all want to look at what happens when you have increasing LTP during ECT treatment, because there is some evidence that antidepressant response can correlate with increased LTP. And also using this mechanism, if we have more evidence for it, as a marker for treatment. So it can guide how we might adjust our parameters, especially if we're tracking it and throughout treatment of our patients, and try to improve cognitive outcomes. And then, the question is also, if we have evidence of disrupted LTP, besides adjusting the parameters, can we actually induce LTP? So as mentioned earlier, like beta burst stimulation has been found to induce LTP, as which can be done through TMS on humans, as this was shown in the rodent study earlier. The question is, do behavioral interventions increase LTP, and would cognitively protective medications help? And that is my presentation. So I wanted to thank the neuromodulation group, Dr. Abbott and Dr. Miller, for a lot of guidance. Tom, Brian, and Taylor, and Tom and Brian have worked really hard on developing the paradigm presentation for this study. The Center for Brain Recovery and Repair, who are funding the study. And that's Dr. Quinn and Dr. Richardson, and then Jude, Karen, and Kevin have been helping with actually starting to collect the data. So that's it. Does anybody have questions?
Excellent talk, Dr. Farrar. Thank you. I have a quick question. When we do electroconvulsive therapy, especially when we do like right unilateral, for example, the electric field is mainly focused on the right side and in front, and yet you're using basically the visual cortex. What's your thoughts on the visual cortex being the furthest away from the electric field, or what do you think about that?
That is a great question, and I'm not sure yet. I would like to see. I think we will have to kind of look at what the electric field calculations are and see if we can incorporate that into the model. It will not probably be achieved during a pilot study because we don't have enough participants, but it is something that I agree we should look at. And then the question is also, the electric field versus the seizure. If it's the seizure that's what's actually disrupting the LTP, then it wouldn't matter if we're inducing a generalized seizure. So I think we have been looking at, the E field versus the seizure, and we don't really know yet what it is. But I think this also could maybe help us have some evidence one way or the other.
Thank you.
That went way faster than I expected, so totally fine.
Do you hear me, Dr. Farrar?
Go for it.
All right, my question is this, and this may have already been included in the data that you presented, but I might have missed it. All right, there is a correlation between right-sided electrode placement and memory performance.
Yes.
Is a similar correlation exist between right-sided placement and emotional outcome in terms of depression?
So generally, and Dr. Miller can also follow up on this, but we find that bitemporal electrode placement is more effective for antidepressant response. And a lot of the reason we don't start there is because of trying to avoid these adverse cognitive outcomes.
Okay.
Yeah. So piggybacking on that, yes, right unilateral. When we talk about 60 to 70% of the population responding to ECT depression, the depressed population, a huge chunk of that is right unilateral. If they fail right unilateral, they go to bitemporal, and so. So there is definitely a correlation between doing the procedure and getting antidepressive effects, but obviously in ECT we are stuck with this paradox where the sort of the higher we march up in electric field strength, we get better antidepressant effects, but we get worsening cognitive outcomes. And so that's that's why this is such an important topic.
Thank you.
Dr. Farrar,
Yes.
this is Dr. Vicente over at the VA, and I was wondering if you could give us a little bit of background or explain to us what the components of the California Verbal Learning Test are.
Yes. So my understanding, and I've never performed the California Verbal Learning Test, but it is a test where participants get a list of words and they repeat those words from memory back. And then they do that again numerous times. And each trial is scored. And then there is an interference list of words. That is a separate list of words where they, it's just a completely different list of words thrown in there. And they have that tested again. And then they again repeat the original list of words and from memory, and that is assessed.
Okay. I was curious if part of the process of working through your project, if you had considered using other forms of testing for like visual memory, since so much of your testing site is going to be dependent on the occipital cortex. And perhaps if that has been something you've considered to maybe move some of the learning away from having to be so dependent on language as part of the sort of design.
Yeah, that's a totally fair point. I think, you know, I am also starting with the data that's being collected from the current studies. And so the California Verbal Learning Test is kind of the primary test of memory that's being used. But it's a totally fair point that, you know, this is a visual phenomena, and visual memory would then be something that we would want to track.
Great, thank you.
I'll stop sharing and I can bring the slides back up if needed.
Okay, sounds like no more questions. I want to thank Dr. Farrar for continuing to be on faculty here and working with us, and for presenting today and representing the geriatric psychiatry division. And I want to thank you all for attending. I think there's a link here sent out, QR code for signing in. Please sure to do that. Be sure to do that to get credit that you were here. Thank you all.